Broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, and thank you for joining the Foundation's webinar titled Medications for RLS. My name is Carla Diezenkowski, and I am the Executive Director of the RLS Foundation. Before we begin, please be aware that all attendees will remain on mute during this hour. We thank you for the questions submitted with your registration. Dr. Silber will answer as many questions as time allows at the conclusion of his presentation. After the webinar, you will receive an email with a link to the webinar recording. The webinar recording will also be made available in the member portal of our website. If you are not a Foundation member and would like to view this and other recorded webinars, we invite you to become a member today by going to rls.org. As always, individuals suspecting that they may have RLS or are experiencing a change in their symptoms should always consult a qualified healthcare provider before making a change in their current treatment plan. Information offered in this webinar is for informational purposes and should not be considered as a substitute for the advice of a physician. Visit our website to find an RLS healthcare provider near you. Dr. Silber is a board-certified neurologist and sleep specialist at the Center for Sleep Medicine at Mayo Clinic in Rochester, Minnesota, an RLS Quality Care Center. He is also a professor of neurology in the Mayo Clinic College of Medicine and Science. Dr. Silber is an active member of the RLS Foundation's Scientific and Medical Advisory Board and is the current chair of its Opiates Committee. With a particular focus in neurology, his areas of research include the relationship of REM sleep behavioral disorder to neurodegenerative diseases, drug management, and predisposing factors related to RLS, and epidemiology and pathogenesis of narcolepsy with special preference to the hypocretin system. Dr. Silber, we thank you for sharing your time and expertise with us, and I now invite you to begin the presentation.
Thank you, Carla. It's a pleasure to be doing so. We're going to talk this afternoon about medications for restless legs. I should just emphasize again that this is for background information and no one should take anything that I'm going to say as a suggestion to change your medication or approach yourself. You need to consult your prescribing physicians before doing so. This is an information webinar and is certainly not medical practice. Well, let's see if we can get to the next slide. Good. The objectives this afternoon is to understand the use of medications to treat restless legs, and we're going to talk about 4 groups: iron, dopamine agonists, alpha-2 delta ligands, and opioids. So I'm going to approach this in terms of the 3 categories of severity of restless legs: intermittent restless legs, chronic restless legs, and refractory restless legs. And most of the time will be spent on the latter 2. But just to put that into perspective, intermittent restless legs is defined as restless legs that's troublesome enough to require treatment, but occurs on average less than twice weekly. And when it is at that level, we like patients to consider non-pharmacological therapy, and then if drugs are necessary, intermittent medications, and I'm not going to be discussing these in any depth, but depending on each patient, sometimes we might prescribe intermittent levodopa, the benzodiazepine sleeping tablets, or low-potency opioids, which today is largely the drug called codeine. These would be used intermittently, for instance, before a long plane ride, if one's going to a concert and knows that one cannot sit through that concert, or if one gets clusters of restless legs, as many people do. We don't understand that. 2 or 3 nights, then nothing for a few weeks. That's the sort of situation in which we might use intermittent medications. Again, this webinar doesn't deal with behavioral therapies, but I've listed them there just so you can get a perspective to what's available apart from drugs. And of course, the obvious thing, walking, stationary bicycling, all those things that every restless leg sufferer has learned over the years. Mental alerting techniques. Restless legs is different from insomnia when we try relaxation techniques, which can make restless legs worse. When one is mentally alerted, many people have found out that their restless legs improves. Regular moderate physical activity, reduction in caffeine, We're not going to talk today about withdrawal of drugs, but most antidepressants, anti-nausea meds, not all of them, and over-the-counter antihistamines can worsen restless legs. And if they're not needed for the patient, it's a good thing to try and withdraw them. But of course, if one needs antidepressants, one treats the restless legs and keeps on the antidepressant. We're not going to talk about vibration devices today. That's a whole topic of its own. So let's move to chronic persistent restless legs. And I would suspect that most of you listening today who are restless leg sufferers will fall into this or the refractory category. And that's restless legs, which is frequent and troublesome enough to require daily drug therapy and usually occurring at least twice a week and causing moderate or severe distress. Well, over the years, there's been a lot of different numbers of how frequent restless legs is, but we now have a couple of really good epidemiologic studies from America and Europe showing that the prevalence of this sort of restless legs, chronic persistent at this level, is somewhere around 2% of the population. That's high. That means 1 in every 50 people you look around will have this degree of restless legs. We're dealing with a common illness here. So let's talk first about iron. Now, what do we know? Well, the first thing we know that in some patients with restless legs, if we measure iron stores in the body as opposed to the brain, they're reduced. And sometimes there's an obvious cause. There's a history of blood loss. In premenopausal women, that's usually due to heavy periods. And in older men and women, we always worry about loss of blood from the GI tract, the stomach or the colon, and we worry about that there may be some lesion causing it. And then occasionally we see highly altruistic people who donate blood every 2 to 3 months, as often as can be, and sometimes they have low iron stores. But sometimes we don't find a cause. The iron levels are not below the lower limit of normal. They're in what we would call low normal iron, and there isn't an obvious cause. Now that's in the body. MRI scans, and these aren't routine MRI scans such as you go to get done at a clinic. These are specialized research scans, and autopsy studies of patients with restless legs who've kindly donated their brains for research have shown reduced iron in many areas of the brain in restless legs patients. Now, the problem is we cannot measure iron in the brain in any clinical way. So we are guessing from measuring iron in the body by blood tests what may or may not be going on in the brain. And it's quite possible that there are patients who have low iron stores in the brain, but normal stores in the body. How could this be? Well, the problem may be that these patients have difficulty transporting iron from the body into the brain. What is going on in the brain? Well, we don't know for sure, but we know that iron is necessary for something called the dopamine receptor, and we'll come back to this when we talk about dopamine in a few minutes. So when you're sent for an iron test, what is measured? Well, the most common thing we measure in the blood is something called serum ferritin, but it measures iron stores in the body, not the brain. We also measure the actual level of iron and something called the transferrin saturation, but all of these are measures of iron in the body. So when should one take iron by mouth? Well, the first thing really is, when should one not take iron by mouth? Now, iron you can just go and buy across the counter in the pharmacy or in the drugstore or in the supermarket, but you should not take it unless levels are actually low. Iron has side effects, and you certainly don't want to overload your body with iron. So we consider it when the level of ferritin is less than 50 to 75 micrograms per liter. Now, 50 is normal. The lower limit of normal is usually, depending on your age and whether you're a man or a woman, would be somewhere around 15 to 20. So we're talking about people whose iron levels are technically normal, but in the low range of normal. Now, we always used to say 50. In recent years, we've pushed that up to 75. Do not take iron if your serum ferritin is greater than 75, for the simple reason it won't be absorbed into the body. The methods by which iron is absorbed from swallowing it by mouth across the stomach and the intestine into the body Doesn't work if you've got ferritin levels of more than 75. There's no point in taking oral iron if they're higher than that. If we're going to give iron, we have to give it intravenously, and we'll come to that in a moment. So you and your physician will consider whether iron replacement is necessary for serum ferritin less than 50 to 75. And there are lots of ways to do it. On this slide, I've said ferrous sulfate, but it's no better than ferrous gluconate and a whole lot of other ones available. It's just an example. We're not sure whether it should be given once a day, twice a day, or even 3 times a day. Now, I know from long practical experience that most people are not going to take it 3 times a day. It's just too inconvenient. So I usually say twice a day, but some experts say there's maybe some reason to take it once a day. We're not sure. And it should be taken ideally between meals, because iron, even when the ferritin is below 75, is not very well absorbed. The vast majority of the iron you swallow by mouth goes out in your stools. So taking it with food is generally not a good idea to get the most of it absorbed. So I say take it first thing in the morning before breakfast and last thing at night. And we like to give some vitamin C with each dose, because that increases the absorption of the iron into the body. There are some combination preparations with both, and that may be the easiest way of doing it. Now, iron is not without side effects. Some people get indigestion. Constipation is very common, and one needs to eat a roughage-filled diet with a lot of fresh vegetables and fruit and maybe some bran. And it will turn your stools black. That shouldn't concern one. It doesn't mean you're bleeding from the bowel. We like to recheck the ferritin every 3 to 6 months, and of course the goal is again to try get it above 50 to 75. So let's move on to one of the advances in restless legs management, which is the increased use of intravenous iron. Now, when should intravenous iron be considered? Well, the first 2 indications are pretty obvious, and we've done this for quite a while. There are some people who cannot absorb iron at all if taken by mouth. These are generally people who have had some surgery to their stomach or bowels, such as bariatric surgery, the type of surgery one does sometimes for obesity, or other reasons why they've had bowel resections or stomach resections. But there are also some diseases of the colon and the bowel which don't make it easy to absorb iron. The second indication would be somebody who really cannot tolerate iron by mouth. They get indigestion, which isn't resolvable even taking it with food. They get such terrible constipation they can't manage. But the third one is the one where we're increasing these days in using this. We see people with very severe symptoms who've got in trouble with other drugs and really need a rapid response if we can possibly give it. And we're using intravenous iron more frequently then. So what level of serum ferritin should be a cutoff? Well, we are now considering it for ferritin less than 100, much higher levels than before, if the symptoms are severe. Obviously not everybody, but just if they're very severe. And we do look at this other measure called the transferrin saturation, and that should be less than 45%. We know that if your ferritin is less than 100 and your saturation less than 45%, there's a very low chance of us doing you any harm. We're not going to overload iron in the liver or other parts of the body by giving intravenous iron in this condition. What again we don't know is what's going on in the brain. These patients with very severe disorder with ferritin of 90 or 80, we really don't know whether the brain has low ferritin or doesn't have low iron. So we are guessing to a certain extent. As a result, we can really only predict about a 60% success rate with this approach. And I always warn my patients ahead, this is not a miracle approach. Some people will have a wonderful resolution of symptoms and others will not notice anything at all. So what do we use? Well, I use a preparation called low molecular weight iron dextran. We give a single dose, infuse it over an hour in our infusion center. We give a test dose first, because there's always a low risk of an allergic reaction. I've personally never seen it with the low molecular weight iron dextran, as opposed to the old one, which was a bad one, the high molecular weight iron dextran, but there is a risk of severe allergic reactions with the throat closing in and the blood pressure dropping, called anaphylaxis. Very low risk with what we use, but it's not zero. So we always give a test dose first, and you should always see if you're getting it, that it's in a doctor's office or an infusion center where there's a nurse or physician available to treat you in the very low eventuality that such an allergic reaction should happen. Now, you would expect giving iron intravenously would, by the next day, if it was going to work, you'd have a wonderful response. And I wish it was so, but it isn't always. Sometimes it takes more than 6 weeks to be effective, and we've no idea why that should actually be, because it gets transported very quickly into the brain. Now, let's say you're one of the fortunate 60% where you've had wonderful results. You can repeat it again after 12 or more weeks if the first dose was successful. Generally, we don't repeat it based on the ferritin, we repeat it based on your symptoms. If they start coming back, then we check the ferritin again and check the percentage saturation and decide whether to give a further dose. Well, that's a brief summary of iron and where we are. Let's move on to the dopamine drugs. Dopamine is a normal neurotransmitter in the brain associated with control of movement, arousal, and the reward system. And drugs that increase dopamine work for restless legs. What's going on? Well, in the picture you can see there's a cartoon of a neuron. At the top is what's labeled there as a brain cell, and there's a long curly line coming out of it. That's called the axon, and electrical impulses travel down that axon to its end, where you can see it look a little swollen there at the end. Then that end of the axon releases a chemical which crosses over to the next brain cell, which is shown in blue here. That chemical crosses and binds to a molecule, a protein molecule on the surface of the second cell called a receptor. Now, your brain has many neurotransmitters. The one we're interested in are the neurons in whom the neurotransmitter is the chemical dopamine. It's shown by a red arrowhead. You can see it being released from the first orange cell, crossing that synapse, as it's called, and binding to the protein receptor on the other side. We don't know exactly what's wrong with the dopamine system in restless legs, but most evidence is now pointing to the fact that there are too few dopamine receptors on the second neuron in the system. Well, what drugs do we have? Well, we have two drugs taken by mouth called pramipexole and ropinirole. Those of you with restless legs probably are very familiar with at least one of these. They bind to the dopamine receptor and bluff the brain into thinking they're actually dopamine. They're approved by the FDA. There are huge trials of more than 1,000 patients showing that they work. Generics are available. But now we come to perhaps the most important point of all. We used to use much higher doses. Nothing like the doses used to treat Parkinson's disease, and I should mention that all of these dopamine agonist drugs were first developed to treat Parkinson's. It may be self-evident, but I do want to make the point that the fact that the drugs work both for Parkinson's and in much lower doses for restless legs does not mean that restless legs patients are at any greater risk of getting Parkinson's disease than the general population. They are not at greater risk. The two disorders are not closely related. It's coincidence that the drug, or roughly coincidence that the drug works for both these conditions. So I don't want to get into detail on doses, but in general today, it would be unusual for us to use pramipexole in a daily dose of greater than 0.75 milligrams or ropinirole in a greater dose of 4 milligrams. The third drug is the patch, the rotigotine transdermal patch. Again, approved by the FDA, trials demonstrate efficacy in more than 1,000 patients. It's applied once a day. Skin reactions do occur with this drug. They're not at all uncommon, but most people tolerate it reasonably well, and one just has to move it around to a different site each day. There are patients who you get skin breakdown and we can't use it. The doses are 1 to 3 milligrams. Again, for Parkinson's, much higher doses used, but those are the standard doses. Part of the problem with the use of rotigotine is its cost. Up till now, the company has provided a voucher for non-Medicare patients, which covers much of the co-payment. For reasons that I don't quite understand, it's not available to patients on Medicare, which makes the cost sometimes more than most patients can afford, unfortunately. So how successful are these drugs? When they first came out, they seemed to be the cure, the solution for restless legs. I'm talking about the 1990s, and we thought for a few years that restless legs is solved. We just have to educate enough physicians about these drugs, and this problem's going to go away. And unfortunately, it's, as most of you know, it's not like that at all. In the controlled trials, if we look at a measure of how much or very much improved restless legs, the numbers are very consistent. If you look at that on the slide, somewhere between about 50 and 75% of patients feel they are very much improved or much improved, but that still leaves 25 to 50% who are less than that, and that's in shortish trials of a few months. So these drugs are not as miraculous as we thought, but they're still pretty effective over at least the short term. What about long-term studies? And we've got 3 studies mainly here. The first study on the first column under pramipexole is the study we did here at Mayo Clinic. We had 50 patients, and after 5 years, 90% were still using pramipexole, 82% by 10 years. The second study is from Hopkins, and much fewer were using it. By 10 years, only 25%. And part of the difference is the Hopkins approach has been, as soon as any augmentation, which we'll come to in a moment, develops, they take the patient off the drug. We've tended to try and work with the patient, at least in the past, to keep them on as long as possible. There's a shorter 5-year study on rotigotine, and disappointingly, after 5 years, only 43% of the patients were still on the drug. So fewer people use the drug as time passes. And why is that? Well, there are some mild side effects that most people don't get in the doses we use: lightheadedness, nausea, nose congestion, leg swelling, and sleepiness. We always warn patients about sleepiness. That can be a problem. It can cause sleepiness driving, though most often, of course, we give the drug at night. But if any sleepiness does develop driving, we encourage people to pull off the road immediately, because sometimes sleep attacks have been reported where people have fallen asleep with very little warning. That seems to happen most often with the higher doses used for Parkinson's. But there are 2 serious side effects, which again, those of you who've been using these drugs for years are going to be familiar with: augmentation and impulse control disorders. Let's consider each. So augmentation is the development of worsening restless legs with time, with increasing doses of dopaminergic medication. In some people, it can start within months, others within years. What does this actually translate to in practice? Well, the commonest things patients experience is earlier onset of symptoms. For instance, if you were plagued with restless legs from 10 o'clock onwards at night, and you were started on pramipexole at 8 o'clock, and everything melted away beautifully, and then 6 months later, you're starting to get restless legs at 6 p.m., earlier than you did before, that's likely to be augmentation, moving it earlier in the day. Some criteria say 2 hours earlier than before, some 4 hours, it doesn't matter. The other thing which sometimes happens is spread to the arms or the trunk. It's a strange geographic spread. One doesn't think of restless legs as an arm problem. I had a patient this very morning whose restless legs had moved almost entirely to his arms. And then shorter duration of response. So as one continues to use it and increase the dose, not only is it coming earlier in the day, but it's not working as well at night. One may work for an hour or 2, and then at midnight or 1 a.m. one wakes up with restless legs again, which didn't happen when one just started on the drug. We don't understand augmentation well or why it happens, but it is common. So here is a typical history of what I see so commonly these days. 55-year-old woman had restless legs from the age of 19 years, in bed only before sleep at night. 8 years before, pramipexole was prescribed, initially at 0.5 milligrams an hour before bed, with good results. And then over the 8 years, the symptoms have worsened and the dose was increased to 0.5 milligrams on waking in the morning, at 2 p.m. and at 5 p.m. with 2 milligrams before bed, with a total daily dose now shot up 7 times higher to 3.5 milligrams. And the reason her doctors gave more and more is that the symptoms were coming earlier and earlier in the day. And each time the physician gave an earlier dose, it came earlier again. And it stopped working at night, so that shot up from 0.5 milligrams to 2 milligrams. And she now comes to see me with restless legs whenever she sits down from 9 a.m. onwards, resulting in only 3 to 4 hours sleep a night. I suspect that at least some of you listening to this webinar might have gone through this. So how common is augmentation? Well, here is the Hopkins study. Concentrate on the brown line in the middle of the screen. That shows how many patients are still on pramipexole up to 10 years later, and you can see it's a steady drop down. They reported about 70% of patients had it over 10 years. The next slide is our data from Mayo, slightly lower, 42%. So I think it's fair to say that somewhere between 40 and 70% of patients will develop augmentation over 10 years. That's a lot. That is probably over half the patients who start on the drug. What are the risk factors for augmentation? Well, perhaps the most important is the high dose. And we've learned just from experience over the years, keep those doses at the levels I mentioned earlier. The higher you push the dose, the greater the chance of augmentation. Then we've also learned that augmentation risk increases the longer you are on the drug, and perhaps the longer you've had restless legs. We also know that lower iron stores may make augmentation more likely, and then greater severity of symptoms before treatment. If before you were put on one of these drugs, restless legs already started in the afternoon rather than the evening, there seems to be a greater risk of augmentation. We know that the very short-acting levodopa, which you remember I said we use intermittently, sometimes for intermittent restless legs, has a very high risk, and we never use it continuously. The agonists probably pramipexole and rotigotine have a greater risk of augmentation than the longer-acting rotigotine, pramipexole and ropinirole have a greater risk than the longer-acting rotigotine patch, but that's not certain. And in fact, on a 5-year study, the augmentation rate on rotigotine was 36%, not all that different from the drugs by mouth, but perhaps more significant, the group doing the study found that they could continue the patch, just changing the dose a little, and the discontinuation rate was only 4%, so it sounds perhaps that augmentation is a little less severe with rotigotine, but it certainly still does occur. Okay, the other bad thing that happens with these drugs are the impulse control disorders, and that is the development of gambling tendencies, shopping tendencies, hypersexuality, and other compulsions. How common is this? Well, in our controlled study we found it as high as 17% compared to 6% in controls. Other studies have shown 6 to 12%. So, if you want to think about it as 1 in 10, somewhere between 1 in 6 and 1 in 10 people will get this. And it doesn't start immediately. That's very important to remember. It may start only 9 months later. So we really warn our patients about it. We ask them at every return visit. We like a family member to be aware of it as well, because strangely, sometimes the patients seem to forget that they've been told that it's due to the drug. When you first tell a patient about this, people laugh. It seems so strange and bizarre, but it's by no means a laughing matter. We've seen patients near bankruptcy from really compulsive shopping or gambling. I've had a few people in trouble with the law with sexual behaviors. This can be serious. But the most important thing is actually positive. If you stop the drug, it melts away all those impulses in about 48 hours. So this is controllable. It's not a reason not to use the drug. One just has to be aware of it. Okay, I'm going to come to how it all fits together in a few minutes, but let's change direction now and talk about the second group of first-line agents for chronic persistent restless legs. And that's the group of drugs with various names. They've been called the calcium channel ligands. In the restless legs world, we're tending today to call them the alpha-2 delta ligands. They've also been called the gabapentinoids, after the name of the first drug, gabapentin. So what are they? They are three drugs: gabapentin, gabapentin N-acarbol, which is a slow-release drug given once a day. Gabapentin is not well absorbed, and what gabapentin N-acarbol does is it's well absorbed into the body. Once it's in the body, it slowly releases gabapentin over the course of the day. And pregabalin. Now, these drugs were first developed for epilepsy. They're not particularly good drugs for the control of seizures. Then it was discovered that they work very nicely for chronic pain, and after that, discovered they work for restless legs. They are not without their own side effects. What don't they do? They do not cause augmentation. They do not cause impulse control disorders, but they do other things. They can make one sleepy. Again, if one's taking it just at night, that may be an advantage in somebody who can't sleep from restless legs, but during the day, it may be a problem. In older people, especially, dizziness and unsteadiness may be a problem. Weight gain is a definite issue with these drugs. Leg swelling can occur. Some people describe a strange mental fogging in the morning and can't take them as a result. And then it's important to realize these drugs have been described as increasing depression, and in people prone to depression, even suicidal thinking. So this is, again, these are not harmless drugs. One has to be aware of side effects and watch for them. So let's talk about each in turn. Gabapentin is it's the commonest used, but the least evidence for it. There's really only one small trial of 24 people showing that it works. But the advantage is its cost. It's generic, it's relatively cheap. It's not well absorbed. We really don't always know from the dose we're given by mouth what the actual level is in the blood or the brain. The nice thing, however, is you've got a wide range of dosing. The usual dose which works would be somewhere between, I've said 2,400, that's a high dose. Most people will get some response between 900 and 1,800 milligrams daily, and you can build it up slowly. The second drug is the slow-release drug, the prodrug of gabapentin, called gabapentin N-acarbol. Huge trials have been done, more than 1,000 subjects, and look how effective it is. Very similar to pramipexole and ropinirole. Again, somewhere between 2/3 and 3/4 of patients responded well to it. The FDA has approved it on only one dose, 600 milligrams, given daily at 5 p.m. It's sometimes used off-label up to 1,200 milligrams. And then I should just mention, of course, that this is also not generic. The third drug is pregabalin. There's been a very large European study showing that pregabalin is at least as effective as pramipexole, maybe more effective, but it does have more side effects. No augmentation, however, much better absorbed into the body, and the usual daily dose is 150 to 400. Oh, that should be 450 milligrams, I'm sorry. The average one would be 300 milligrams. So, let's try and put this together for chronic restless legs. The first thing is we want to prevent the dreaded augmentation if we're going to use dopamine agonists. How do we prevent it? Well, the first thing we do is consider whether we should use the alpha-2 delta ligands rather than dopamine agonists at all. If we've got intermittent restless legs, the first category I talked about, don't rush into using dopamine agonists. Use intermittent therapy if restless legs is infrequent. Then if a decision is made to use pramipexole, ropinirole, rotigotine, keep those doses as low as possible. Monitor for early detection. The physicians should monitor, but the patients also need to understand what augmentation is and monitor for it, especially as duration of treatment increases. I'm seeing more and more patients who are extremely knowledgeable. They come and see me and say straight away, I've read it up, I've got augmentation, and they're right, of course. And then keep iron stores replete. So what do you do? What should I do as a physician when you come and see me? I've not been on any treatment before, and I diagnose chronic persistent restless legs at least twice a week, causing moderate or severe distress. Well, as we've discussed, there are two choices, the dopamine agonists and the alpha-2 delta ligands. Which should we choose? Well, we think probably if the restless legs is very severe, one should still start with the dopamine agonist. That's not certain. If there's active depression, you probably don't want to use gabapentin or pregabalin because that can worsen depression. Remember, if those drugs can also increase weight, so we'd be swayed to move towards the dopamine drugs in very obese people, or if they've got what we call metabolic syndrome, obesity with high blood pressure, high cholesterol, high diabetes, greater risk of heart disease. We don't want to push the weight up if we can help it. On the other hand, as you remember, the alpha-2 delta ligands like gabapentin were noted to be very good with pain. So if you have the painful variant of restless legs, or restless legs plus another pain syndrome like a painful peripheral neuropathy, these may be great drugs to start with. They may be helpful for people with anxiety, and they're sedating. So if you've got insomnia and restless legs, some people have both. I mean, of course, restless legs can cause insomnia, but some people have a form of insomnia called psychophysiologic insomnia with an active mind and restless legs. This may be a really good choice. And then if you've previously had impulse control disorders or addiction, you may want to avoid those dopamine agonists. Now, what if there's none of these? You've just got a patient with restless legs. This is a real change in the last couple of years. We are now saying consider starting not with pramipexole or ropinirole, but starting with gabapentin, gabapentin enacarbil, or pregabalin. If it doesn't work, we can always move to the other ones, but if it works, you've avoided the whole problem of augmentation. Okay, let's say we started on the dopamine agonists, and worst has happened, augmentation is developing. Symptoms are developing early in the day. How do we manage that? Well, we always check the iron stores. And if this is mild augmentation, all that's happened really is it's moved 2 hours earlier in the day. Your total dose of, say, pramipexole is not at the upper limit of normal yet. Well, we might split the dose. Instead of giving you the whole dose at 8 p.m., we'll give half at 8 p.m. and the other half at 5 p.m. and see if we can control it. If we can't, we might very cautiously increase the total dose once, never getting above that 0.75 milligrams, watching for progressive augmentation and stopping it if that occurs. If that's not practical or doesn't work, we might consider one change in the dopamine agonists, moving from the oral ones, if that's what you're on, pramipexole or ropinirole, to the patch. Because again, as I mentioned, it seems that augmentation in the patch may be less severe, if not slightly less. So we might change to rotigotine and watch it carefully. If we don't want to do that, or that doesn't work, we're going to recommend coming off the dopamine agonist, and we're not going to talk today about how to do that. There are various ways, and change to an alpha-2 delta ligand like gabapentin or pregabalin or gabapentin enacarbil. All right, now let's move to the third group, the really troublesome restless legs called refractory restless legs. And this is restless legs unresponsive to single drugs with tolerable doses of first-line agents. In other words, you've tried a dopamine agonist, moved it up to the maximum dose without side effects or augmentation. You've tried an alpha-2 delta ligand, it's not tolerable or not working. So either due to the fact it's not working, or with the dopamine agonist, augmentation not easily controllable is developed, or side effects on either group have occurred. You've tried both types of drug, you know you can't, that it's not working well. That's refractory restless legs. And unfortunately, in patients who've been using dopamine agonists for long periods, we're seeing more and more people in this category. So what do? Reassess the iron stores. Consider IV iron therapy as we discussed. I always consider other exacerbating factors. Are they on antidepressants or antihistamines or other drugs which could be worsening it? Do they have sleep apnea? Sleep apnea by fragmenting sleep could make restless legs worse. And then we've got a couple of things we do next. We consider combination therapy, reducing the dose of the first-line agent and adding one or more alternative agents. In other words, if we're having side effects on pramipexole, maybe we can reduce the dose down to a half or a quarter of what you were on and add, say, gabapentin or pregabalin in a lower dose than we might have used. And sometimes combination therapy works. And I've got patients on 2 drugs and occasionally even on 3 in lower doses. But if that fails as well, and the intravenous iron isn't the answer, and the other exacerbating factors aren't there, we then consider substituting a medium or high potency opioid, which brings me to the last topic today, which is the opioids. Well, these drugs are very effective for refractory restless legs. In a big study, there were 2% serious side effects, vomiting and severe constipation. That's low. Our doses are very low compared to those with chronic pain. And I think that's important for physicians and everyone else to understand. Probably a quarter, at least, of the doses used for chronic pain. Studies up to 10 years have shown little tolerance or dependence to these drugs. Now, it's not zero. I have a few patients in my practice who have developed dependence on opioids with rapidly increasing doses. It's rare, it's not, but I think I would be untrue to the understanding of what we're doing if I said it was zero. It's not, but it's really rare. What do we use? Oxycodone, either short-acting or long-acting, methadone, morphine, and others. I don't want to go into doses here, but those of you who are familiar with these drugs will know these are relatively low doses. I'm finding insurers are being less comfortable paying for oxycodone, especially the long-acting form known as OxyContin, and I'm finding nice results with slow-release morphine as an alternative. Methadone is very effective. It has some side effects of its own, and again, it's hard for some patients in some states to get it. What are the side effects? Well, some patients get itch, and that's not an allergic reaction. It's a strange side effect of the drug. Constipation, nausea, and vomiting are classic side effects of opioids. My patients don't seem to be madly troubled by these, perhaps because of the low doses. In older people, it can cause some memory decrease, gait unsteadiness, falls. These are risks, especially in older people. And then we always think about sleep apnea. Opioids can cause or worsen obstructive sleep apnea, or strangely convert previously well-controlled obstructive sleep apnea to a different form called central sleep apnea. So we think about that. We always worry a little about overdose, especially in depressed people, either inadvertent or deliberate. And then addiction, as I said, rare but not zero. So when I'm thinking, have a patient who I need to put on opioids, I think it's only fair for all physicians to assess the risk of addiction, and there have been many, many studies showing it is more common in young white males, a family history of addiction, a personal history of drug or alcohol problems, in patients with coexisting psychiatric disease. Now, we certainly don't withhold opioids in people with any of these if they need it, but we use something called the opioid risk tool to assess risk. And if the risk is high, we monitor the patients more carefully. But I do not believe that any of these are absolute contraindications they use if they need it. So what are the issues with opioids? Those of you who've been put on opioids will recognize many of these. The first is the confusion of restless legs with chronic pain, together with widespread opioid addiction problems in the country. This has led to insurance reimbursement issues, with insurers declining to cover opioids. Providers fear of professional consequences. Physicians who say, I've made a decision now in my practice, I never use opioids, will not prescribe them, and they don't separate out restless legs and chronic pain. And then the threat of restrictive administrative rules or legislation, either at state level or at national level, to restrict chronic opioid use. And the sort of things we worry about for our patients are laws which might say you can only give 2-week supply at a time, or limit the number of tablets you can get, or limit prescriptions to pain management doctors who don't understand restless legs. So those are things which are concerning to our patients and to us in this setting, because restless legs is not chronic pain. It's a different disorder. It responds to much lower doses with lower risk of addiction, and we certainly don't want to deprive our patients who need opioids. So I encourage all of you to work with the foundation to educate providers, educate insurers, and educate legislators. Legislators listen to grassroots lobbying. They're more interested in their constituents talking to them than necessarily foundations and experts. So it's so important that patients who are having any difficulties in this way start to work with both state and federal legislators. So what's responsible opioid use? Well, I always start by talking to my patients about the opioid epidemic, and I explain why we have to be responsible. I make it very clear that I'm not accusing them of being potential addicts, etc., because they tell me stories of how some physicians out there are making them feel like addicts. One thing that I've come across is physicians who demand random drug counts. The patient gets phoned up and said, you've got to come in today with your medication, we're going to count the numbers. To me, that is intrusive and unnecessary. That goes beyond what I think is a responsible provider. That may be necessary for people with past histories of addiction who are on high doses for pain. I understand that, but routinely for the average restless legs patient, that goes beyond what we need. So I explain that because of the opioid epidemic, both providers and you as patients need to be responsible, and we need to put into place some things which might feel unnecessary, but it's necessary to allow everybody to feel we're doing the right thing. So we ask patients to sign an opioid contract. We make it clear we're not going to refill early. We don't want people to call in and say, I lost my prescription, I lost my drugs. We might replace them once, but we tell them if that happens again, we're not likely to do it again because we're worried. And we also tell patients, please don't change what you're taking without discussing for us. Don't call up and say, my restless legs was more severe, and therefore I've doubled the amount of oxycodone I'm taking. If it's severe, give us a call. Let us work together on it. Of course, opioids from only one provider. We do random urine drug screens. In practice, that means before we start it, usually once a year or sometimes once every 6 months. I'm not at all sure that's terribly helpful. The idea is to show that you really are taking it and not selling it on the street, which for the majority of our patients, they laugh at me and say, how would I be able to get any sleep if I was selling my opioids on the street? The other thing is the idea is to check that the patient's not taking any other drugs. So I'm not at all sure that's terribly helpful, but we do it. We use state prescription monitoring programs where we check that patients are not getting it from from two providers. And we frequently reassess response and side effects, usually 3 to 6 monthly visits. We do not do in our center anyway monthly visits. We do provide repeat prescriptions with just on being called in. We don't expect the patient to come to the office every month. I know many providers are doing that. Okay, well, that's what I have to talk about today. I hope that's all been helpful, and I hope we have some time for, I'm sure, many of your questions. So thank you for attending and listening and supporting the foundation.
Thank you, Dr. Silber. We'll go ahead and get started with the questions. Some will be a reteach of what you've just said. We've had over 20 people come on to the webinar midway through, so I wanted to make sure we touched base on some of those important topics. First question is, how can I tell the difference between augmentation, normal and mild continuing symptoms of medicated RLS on pramipexole?
It can be difficult to do that, especially if restless legs is worsening for some other reason, such as an antidepressant or iron levels are dropping. Augmentation, it usually moves earlier in the day, and then the effect wears off at night. And usually, if the dose increases, it gets worse rather than better. Those would be the essential characteristics. But yes, it can be a little difficult, and sometimes it needs an expert who's worked with lots of restless legs patients to be sure it really is augmentation rather than the disorder just worsening for some reason. If any of these things happen, consult with the person prescribing the drug.
What is the best medication in terms of little chance of developing augmentation?
Well, I'm assuming the question concerns people with chronic restless legs who are going to need daily medication, and I think we covered that earlier. Today, if you want to have the lowest risk of augmentation, it would be one of the alpha-2 delta ligands, gabapentin, N-carbo, or pregabalin. And I should mention, maybe it was obvious, but gabapentin and pregabalin are off-label uses for restless legs. Only the gabapentin N-carbo has been approved by the FDA. There may be reasons not to use those drugs, as we went through earlier. people who are definitely markedly obese, who have active depression, you probably want to think twice about using those drugs. But if your only consideration is what's the lowest risk of augmentation, those are the drugs to use rather than the dopamine agonists. But each patient is different. We have to balance the different side effects of the different categories.
Okay. What effect, if any, do opioids have on sleep disruption associated with RLS?
Opioids can be wonderful for sleep disruption associated with RLS. You know, I always ask people when they come back, have you got sleepy during the day? Because opioids can do that. Are you okay driving? And most patients who've had a good response will say, Doctor, it's wonderful. I couldn't sleep at all with restless legs. I'm much more alert taking opioids at night than I was before I took them, which surprises some physicians because they're expecting their patients to have these dreadful daytime side effects. But low dose at night, most people will have a very nice sleep because we're getting rid of the restless legs, and opioids are somewhat sedating.
Okay. Is there a maximum safe dose of gabapentin?
No, gabapentin is used often for chronic pain up to about 4,800 milligrams a day total dose. Usually the limit is side effects. As dose gets higher, patients start describing unsteadiness, dizziness, mental fogging, but there's no single, well, I suppose 4,800 milligrams a day is the maximum dose that we would use. It would be unusual to get near that dose in restless legs. Just from my experience, most people who aren't responding to 1,800 milligrams are probably not going to respond well to gabapentin, though they may to pregabalin.
Okay. What options are there for treating insomnia that don't either lead to dependence or exacerbation of RLS symptoms?
I'm sorry, would you repeat that one?
The question is, what options are there for treating insomnia that don't either lead to a dependence or exacerbation of RLS symptoms?
Okay, I presume the question relates to insomnia unrelated to restless legs, patients who has both what we call psychophysiologic insomnia, learned insomnia, active mind, and restless legs. Well, our approach to chronic insomnia disorder today would first be to identify contributing causes such as anxiety, depression, restless legs, chronic pain, sleep apnea, etc. If there are no obvious contributing factors which can better be addressed, then our approach today tends to be cognitive behavioral therapy for insomnia rather than medications. So we would generally recommend cognitive behavioral therapy, which can be administered by really any knowledgeable health provider. It can be done by nurses, by physicians, by psychologists. And today what's nice is it can be done online. There are various online programs available, self-help programs. So there are many ways it can be done. But for chronic insomnia, we're tending to avoid medications as much as possible. And I think the medications for insomnia are somewhat beyond the scope of this webinar today.
Mm-hmm. Okay, and we have a lot of questions on opioids. Is there a particular opioid that you prefer to use for those patients who don't get relief from other remedies?
Well, there are various choices on the market, and it really depends on individual providers and what they're familiar with. For instance, at Johns Hopkins, where they've had probably more experience with opioids than anywhere else, methadone is definitely their drug of choice. We've tended to start with oxycodone, often in the long-acting form. Morphine has been used. I think it's variable. It depends on what each provider is familiar with. I don't think there's a specific rule, and I think you have to work with your individual provider.
Okay. Next question is, please discuss the benefits or adverse events of supplements as well. They would like you to talk about iron, magnesium. Do those help with RLS management?
I don't believe that magnesium has been clearly shown to help, even though there were some studies early on. Unfortunately, I don't think any supplements really help, with the exception of iron. And as I mentioned earlier, one should not just take iron, one should have one's levels measured and work with a physician about how much iron to take and how long to take it for. I'd love to be able to tell you that all the various vitamins and other minerals help, but there really is little evidence in general that they do.
Okay. Next question is, how long can an RLS sufferer use an opioid without becoming addicted?
The majority of our patients don't develop long-term addiction, and there are patients who've used them for 10 or more years without problems. The dose might slightly increase, but not generally. So there's no cutoff in a patient who is genetically not predisposed to developing addiction and whose chemistry in the brain doesn't seem to cause addiction. We've had people for years on opioids without a problem. Addiction can occur very quickly after starting it in a small minority of patients or slightly longer. It's rare in the doses we use, especially with the precautions we use, but it's not non-existent. But nevertheless, there's no specific time. A person who's not going to get addicted could go decades in theory without developing it.
Okay. Do you know if there's any research being done on the correlation of histamines and development of RLS?
I'm not aware of any active research being done in that. We certainly think that over-the-counter antihistamines can worsen restless legs. That's just clinical experience.
Mm-hmm. What information is there about CBD oil as an option for treating RLS?
Which oil? Is
CBD?
that cannabis?
Yes.
Is that what the question is?
Yes.
There are no good studies on cannabis and restless legs. From states in which cannabis is more easily available, there are some physicians who say they've had good results from it. I have no personal experience with it at all, and I can't really give any more information than that. I'm sure studies will be developed and we'll get more objective data in the future.
Okay. I'm just going to keep going through. Is it possible for your whole body to be affected by RLS symptoms?
Well, we've seen augmentation spread not just to the arms, but the trunk as well. There are some unusual people with restless legs, which even from the beginning, it seems to involve the back or the pubic area, or sometimes the arms more than the legs. So yes, it can affect different areas of the body. The vast majority of patients before augmentation develops will have it in the legs. When from the beginning it's really in some other area of the body, I'm very careful to be sure that it is restless legs and it's not some other disorder mimicking restless legs. But yes, I've seen patients in whom the restless legs right from the beginning was in the low back, but that's quite unusual. The whole body from top to toe, that would be unusual, and I'd worry about a couple of other conditions.
Okay. Which drug is worse for the body, opioids or dopamine agonists?
That's not a possible question to answer, I'm afraid. Each one has its advantages and disadvantages. We do restrict opioids to people who failed the other forms of treatment, including the dopamine agonists. I can't tell you which is worse for the body. They both have different side effects and different problems.
Okay. Let me see. Is it possible for a medication to continue to work for a person, or is it true that all medication eventually stops working for everyone with RLS?
No, that's not correct. There are many people on stable doses of medications for years and years. Augmentation doesn't happen on every patient on the dopamine agonists. There's some people on low doses with milder restless legs who've used them for a decade or more, even though the majority will get augmentation. Similarly, there are people on gabapentin or similar drugs and people on low-dose opioids who've been stable for many, many years. It is not inevitable that the drug will wear off with time, though in many patients, problems do develop later on, especially with the dopamine agonists.
Okay, and this is a question that we get a lot at the foundation, is about drug holidays. Do you recommend drug holidays, and if so, how often should a person do them?
I do not personally recommend drug holidays. They're extremely difficult to achieve, especially in severe restless legs. Patients suffer through them, and there's really not good evidence that a drug holiday is going to allow the drug which gave problems before to reestablish itself as effective after the holiday. If you've got augmentation on the dopamine agonist, putting it back on again after a holiday, you're just going to get more rapid augmentation again. So I do not favor drug holidays, although they've been used on and off for 30 years for the management of restless legs by some physicians. They've never been good studies showing that they work.
Okay, and then I'll go to our last question, and I just wanted to have you give our thoughts on our visit to Washington, D.C. We were part of a group, from the foundation that visited with our legislators and agency officials to educate them about RLS diagnosis, treatment, and management. Is there any important takeaways that you'd like to share with our webinar attendees today?
Yes, we had an interesting visit to DC. We met with the NIH, we met with the FDA, and we met with the staff of many, as many as 18, I think, senators and congressmen. On the whole, people were understanding of the message we were giving, which was that restless legs is different from chronic pain, that we are very sensitive to the opioid epidemic and understand why regulations and legislation is being considered, but we asked for what's called a carve-out for restless legs, that in any such regulations or legislation, restless legs be specifically mentioned as not being associated with restrictions in the use of opioids. And I think people understood what we were saying. We began to educate people on restless legs, and hopefully will make a difference as we move forward. The foundation has been very proactive in this respect, and I think correctly so. It's probably one of the biggest challenges restless legs patients are going to be faced in the next few years. A good job's been done in DC, and the foundation is going to continue to follow that up. But I think it is very important for everybody, as I mentioned earlier, who has this problem or wishes to help, to contact their own congressmen, their own senators, and their own state representatives as well, to say, look, this is an issue for me. Please be aware of this as you consider any potential legislation. And I hope people will work with the foundation in this respect.
Well, thank you, Dr. Silber, and I'm going to piggyback onto that and ask everyone on this webinar to join us on Monday, April 16th at 1 o'clock Central Time to visit with Dane Christensen of the Health and Medicine Council of Washington, D.C. to discuss legislative updates and opportunities for congressional outreach so that you can go into your communities and talk to your congressional persons when they're on holiday this summer. And we'll put you in touch with Peter Herzog. We'll help give you your talking points and allow you to share your story. As Dr. Silber mentioned, the most important thing they want to hear is from their constituents. So we'll do our part, and we need you to do our part, and together we'll strengthen our voice and make the case for RLS here in DC. Dr. Silber, I thank you for joining us today. Your presentation was so helpful and informative to the RLS community.
It's a pleasure. Happy to help.
All right. Have a good afternoon, everyone.